Okay, in this lecture we'll be talking about lumbosacral radiculopathies and plexopathies. And first of all, I just want to appreciate anatomically the overlap between these two conditions. And especially we'll think about lumbar radiculopathies involving nerve roots L2, 3, 4, and we'll contrast that with lumbar plexopathies. Okay, much overlap there. And then we'll consider L5 and S1 radiculopathies with sacral plexopathies. And again, much more overlap, a lot of overlap between those conditions. I won't be drawing out the plexus and the nerve root anatomy like we did for brachial plexopathies. You can see a picture of it here. It's a lot more complex, as you can see. But I would like to point out the distinction here between the lumbar plexus and the sacral plexus. Okay, and I also want to just point out one nerve that you probably haven't heard of before. It's called the Furcal nerve, F-U-R-C-A-L. And this will come up later, but this is an important contribution between the lumbar and the sacral plexus. Specifically, that carries the L4 fibers that go down to the important muscle below the leg to dorsiflex the foot. There's really only one L4 muscle below the knee, and that's tibialis anterior. Okay, and that's L4 and L5 innervated. So again, someone with an L4 radiculopathy or a lumbar plexopathy could potentially have a foot drop because of that overlapping feature between the lumbar and sacral plexus. All right, so let's start with radiculopathies in the low back. These are certainly much more common than plexopathies. And just as when we went through radiculopathies in the upper extremity, we want to kind of go through it in the same manner. Symptoms are very similar. So patients usually present with back pain and radicular pain down the leg. Remember what that is like. It's a shooting, zipping, electrical quality down the leg. And patients have sensory symptoms in the involved dermatome. All right, so again, you can see a diagram there on the screen showing you the different dermatomes. So just appreciate that the L2 dermatome is primarily the anterior thigh area. L3 extends down into the medial leg and inner thigh area, and especially around the knee. And notice, very important, the L4 dermatome extends down to the medial calf area. All right, so as we're trying to sort this out between L2, L3, and L4, if a patient has back pain, shooting pain down the leg, and the medial thigh is numb and tingly, that would suggest primarily the L4 nerve root is involved. Okay, L5 extends down the lateral leg, especially below the knee, and onto the dorsal surface of the foot. Okay, so if we have back pain, shooting pain down the lateral leg, and the top of the foot is numb, that sounds like an L5 radiculopathy. All right, S1, by contrast, extends down the back of the leg. Okay, and the plantar surface of the foot is numb. All right, and sometimes the fifth digit may be numb as well, even on the dorsal surface. Okay, so the sensory dermatomes are quite distinct. One other point about S1 radiculopathy, patients will often refer to this as sciatic neuropathy or sciatica. Sciatic neuropathies are extremely rare. So even if we use the term sciatica, we're really referring to an S1 radiculopathy. All right, so we have sensory symptoms, and then we have motor and reflex changes. And let's go through the different nerve roots here. For L2, 3, 4 radiculopathies, the muscles that will be affected will be iliacus and the hip flexors. Okay, so there'll be proximal leg weakness. Also the quadriceps muscles, such as vastus lateralis, rectus femoris, those will be weak, so the patient will have a hard time straightening their leg out all the way. And also the thigh adductors, such as adductor longus, will be weak as well. All right, so with either an L2, 3, or 4 radiculopathy, we'll have weakness above the knee. Okay, and then hopefully the sensory change will help to confirm for you which specific nerve root might be involved. One point to make is anytime we're thinking about radiculopathy, to make that diagnosis, we want to find that the weakness, the sensory change, cannot be confined to a single nerve distribution. So for example, an L2, 3, 4 radiculopathy could look a lot like a femoral neuropathy with proximal weakness, quadriceps weakness. Okay, so to really nail it down between nerve root and a femoral nerve, we want to find muscles that are weak outside the distribution of the femoral nerve. So if the thigh adductors are weak, that's the obturator nerve. So you know it can't be a femoral neuropathy. And if it's more of an L4 nerve root involvement, then remember that patient will have numbness in the medial calf, but the weakness then will extend to below the knee, and specifically just one muscle, and that's dorsiflexion of the foot. So tibialis anterior, a very important muscle that has both an L4 and an L5 distribution. Okay, we're going to come back to foot drop once we've gone through the L5 and S1 nerve root anatomy. All right, if the patient has an L5 radiculopathy, remember the sensory symptoms are down the lateral leg, top of the foot is numb. All right, and the muscles that you'll look for in terms of weakness, again, will be tibialis anterior, dorsiflexion of the foot, because that's L4 and L5. Also, we'll look for weakness of the posterior tibialis, which is inverting the foot. Okay, so you ask the patient to turn their foot in. Okay, that has L5 and some S1. Peroneus longus, where the patient everts the foot, is L5 and S1. All right, so the patient's going to have weakness of dorsiflexion, inversion, and eversion, typically, if it's an L5 radiculopathy. And we'll look for other weakness, the hamstrings, for example, asking the patient to flex their leg, pull the heel back against the bed. That muscle would be weak, typically with an L5 radiculopathy. And finally, gluteus medius. How do you check that? If the patient's sitting, you just ask them to abduct their knees, spread their legs apart. You push against the knees as they try to do that. Okay, gluteus medius is a very strong L5 muscle. Okay, so again, the movement in the foot, dorsiflexion, eversion, inversion, hamstrings, and gluteus medius. Those would be 5 good muscle groups to check for an L5 radiculopathy. Now, the trick for an L5 radiculopathy is you're finding all this weakness. Maybe the patient has a foot drop. All right, you're finding the sensory change, but we don't have a reliable L5 reflex. Okay, so your patellar reflex, which would be lost in an L2, 3, 4 radiculopathy, that's going to be preserved if it's L5. The Achilles reflex, which is S1, S2, will be preserved. All right, so even though this is a lower motor neuron problem, you don't have a loss of reflexes. The one L5 reflex we can check is the hamstrings reflex, but it's not very reliable. It's absent in many patients, and so frequently that is not very helpful. Okay, finally, an S1 radiculopathy. This is certainly the most common lumbosacral radiculopathy. Again, back pain, shooting pain down the posterior leg, numbness down into the plantar foot. Okay, and so the S1 muscles you want to check. Again, you may find some weakness with inversion and eversion, because those are L5, S1. But plantar flexion, okay, that's the gastrocnemius. You ask the patient to push their foot down. Okay, that's an S1, S2 muscle. So it'd be very important to check that side to side. And gluteus maximus. Remember we said gluteus medius is L5, that's spreading the legs apart. Gluteus maximus is best checked by having the patient lie flat on the bed and push their heel down into the bed while you try to lift the leg up. Okay, that's gluteus maximus, and that's primarily an S1 and S2 muscle. Okay, so usually it's not difficult to distinguish between the major types of radiculopathy. I want to come back to one point on foot drop. Remember, we can see foot drop with either an L4 or an L5 radiculopathy. And I want to help you try to distinguish between 3 different types of foot drop. 3 most common causes are L4 or L5 radiculopathy, peroneal neuropathy, and ALS, or Lou Gehrig's disease. So we just talked about L4 and L5 radiculopathy. How do we distinguish that from a peroneal neuropathy? Because both patients come in with a foot drop. And again, the key thing, anytime we're talking about nerve roots, the weakness and the sensory change is beyond a single nerve distribution. Okay, so we said if a patient has an L4, L5 radiculopathy, they're going to have weakness with dorsiflexion, eversion, and inversion of the foot. If we have a peroneal neuropathy, again, the peroneal nerve supplies tibialis anterior, so that patient's going to have a foot drop. They're going to have weakness trying to dorsiflex their foot. Okay, and so the single most helpful muscle to distinguish between radiculopathy and perineal neuropathy is just to ask the patient to turn the foot in. Okay, remember that's posterior tibialis. Okay, and that muscle is supplied by the tibial nerve, not the perineal nerve. So if you ask the patient to turn their foot in and it's weak, right away you know this can't be a perineal neuropathy. Okay, it's broader than the perineal neuropathy. We need to put the lesion further up, and typically that's going to be at the nerve root level. Okay, and the sensory change in perineal neuropathy is quite different also. The numbness is generally going to be between the first and second toe on the dorsal surface of the foot. Okay, and just a comment about ALS. We'll have a more expanded discussion on ALS later, but ALS very commonly presents with a foot drop. Okay, but remember, ALS is a pure motor neuron disease. So there's no pain, no sensory symptoms, just weakness. And what you find on examination is typically a mixture, eventually, of upper and lower motor neuron findings. Okay, and again, the weakness, because now the lesion's all the way up in the anterior horn cell, typically is not going to be confined just to the perineal distribution. It's going to be broader. All right, so let's move on now and talk about the lumbosacral plexus. Plexopathies, when we compare these to brachial plexopathies, much, much less common. And we discussed then some reasons for why that might be. In general, there's more protection for the lumbosacral plexus. And again, we want to think of a lumbar plexus and a sacral plexus. And I'm just going to go through a few of the more common causes of lumbosacral plexopathies. Neoplastic is probably the most common, and this can occur either as a direct extension from cancer or from a distant metastatic cancer. So for example, direct extension often will occur with colorectal cancer, uterine cancer, prostate cancer, or ovarian cancer. And these tend to involve, makes sense, the more proximal nerves. So the lumbar plexus would be more commonly involved with direct cancer extension. If the cancer comes from a distant site, for whatever reason, it's more likely to go to the sacral plexus. So we'll often see this with breast, sarcoma, thyroid, and testicular cancer. When we talked about brachial plexopathies, we tried to distinguish between cancer infiltration versus radiation involvement of the plexus. And the same rule of thumb applies here. So again, some patient may have had radiation therapy. Could it be a radiation plexopathy? And the most helpful thing, one of the most helpful things to ask is if pain is the predominant early symptom, it's more likely to be cancer infiltration than radiation involvement. And if there's cancer infiltration, you're going to have weakness, again, perhaps either in a lumbar or sacral plexus distribution, and frequently there's a lot of leg edema that goes along with that. So you get that story, you're going to want to do a CT or an MRI scan to look for evidence of a mass. Okay, so cancer and radiation, that's one. Second, very important plexopathy that involves the lumbosacral plexus, especially the lumbar, you need to know about, is retroperitoneal hemorrhage. And the reason this one is so important is it's iatrogenic. Okay, it's related to some treatment that we're giving the patient, and typically that is IV heparin. So the patient's on a heparin drip, usually supertherapeutic, and this occurs in about 4 to 5% of patients on heparin, so it's not that uncommon. And basically there's a spontaneous hemorrhage into the psoas muscle where the lumbar plexus is formed. So patients at the onset of hemorrhage typically present with abdominal or back pain and symptoms usually of a lumbar plexopathy. So again, lumbar plexus, that's going to be proximal muscles, quadriceps, thigh adductors, most of the sensory changes in the anterior thigh, or if it's L4, perhaps down into the medial calf area. So a patient on heparin presents with those symptoms. Very important you stop the heparin drip immediately. And remember, CT is a very good study for evaluation of hemorrhage. So we'll do a CT of the pelvis and to try to document that, yes, we've got a retroperitoneal hemorrhage. So treatment is usually just stopping the hemorrhage and waiting for the hemorrhage to resolve. Certainly if it doesn't, then we get surgery involved as a possible way to evacuate the hematoma. Okay, another cause of lumbosacral plexopathies are obstetrical or gynecologic lesions. And this usually occurs due to a difficult delivery. Not very common, somewhere between 1 in 2,000 or 3,000, perhaps 6,000 deliveries. And typically the lesion is to the lumbar plexus or sometimes the femoral nerve. Okay, so after delivery, the patient will typically complain of some leg weakness, and since it's mainly lumbar plexus, the weakness is going to be proximal. Once again, how do we distinguish between a lumbar plexopathy and a femoral neuropathy? If it's a lumbar plexopathy, the weakness extends beyond the distribution of the femoral nerve. So it's not just quadriceps and hip flexor weakness. The patient also has weakness with thigh adduction and perhaps with some foot drop if the tibialis anterior muscle is involved. And overall, these patients have a good prognosis. Okay, the general rule of thumb is if the site of nerve injury is close to the muscles involved, patients tend to have a good recovery because the nerves can regrow, rewire. If the site of injury is distant, so for example, we have a sacral plexopathy, patient has foot weakness, those patients aren't going to do so well because of a distance effect. Okay, another iatrogenic lumbosacral plexopathy is due to intravascular injection. So typically when an injection is given in the buttocks area, we want to do it in the lateral portion of the buttocks. But if the injection is not done in the outer gluteal, but instead the intergluteal area, this can stimulate vasospasm. And so typically the lumbar plexus is involved, so this is an iatrogenic lumbar plexopathy. So patients present with symptoms immediately or soon after the injection with proximal weakness, pain, sensory symptoms, and there may even be ischemic changes or gangrene around the area of the iliac crest. Okay, and finally, traumatic lumbosacral plexopathies are not very common compared to traumatic brachial plexopathies. Maybe only 5% of all lumbosacral plexopathies are due to trauma. Okay, but certainly in someone that's been in a severe motor vehicle accident that then presents with leg weakness and with sensory changes, we need to distinguish then, is it radiculopathy or plexopathy? So imaging the spine to see if there's some discogenic involvement, and if there isn't, then perhaps the lesion is to the lumbosacral plexus. Okay, that's all.